The broadcast is now starting. All attendees are in listen-only mode.
Hello, welcome to Identifying and Serving Children with Health Complexity, a spotlight on the Pediatric Care Together program. Next slide. This is Colleen. I'm the director of the Oregon Pediatric Improvement Partnership, and I am so excited to be here today with the leaders and team from Kaiser to share on our collaborative efforts. Joining me today from the Kaiser Permanente Northwest Pediatric Care Together team are Cannon, Kim, Stephanie, Charlene, Vicki, and Joyce. And you'll see their titles and roles on the slide that we had before. Few housekeeping items before we begin. We really want this to be a lively discussion and encourage attendees to ask questions. You can submit questions in the GoToWebinar question box that's on your right. Due to the large number of attendees we have today, all of you will be muted for the duration of the webinar, but we will be tracking the questions closely. A recording of the webinar and the slides will be posted and shared with all registrants via email. All right, so what are we going to cover today? For today's agenda, we're going to start first with an overview and background about our collaboration with Kaiser Permanente Northwest. Then we will briefly go through the design frameworks and key elements of the Pediatric Together program, or the PCT program, that was described in the summary. And if you look in the chat function, you can see a link to that summary that we'll be alluding to throughout the webinar. And then most importantly, we're going to save time for questions for the PCT team so that we can learn from their hard-earned experiences and learning. First, a little background about the Oregon Pediatric Improvement Partnership, or OPIP, as I am going to refer to it. OPIP is one of over 20 improvement partnerships across the country. We support meaningful long-term collaborations of stakeholders invested in child healthcare quality with the common purpose of improving the health of children and youth in Oregon. We are fortunate enough to be based in the Department of Pediatrics at Dornbecker Children's Hospital at Oregon Health and Sciences University. OPIP staff obtain grants and projects that allow us to focus on 4 areas meant to implement population-based and family-centered efforts that focus on 1, quality measurement and improvement, 2, evidence-guided quality activities, 3, ensuring the patient and family voice are incorporated throughout efforts, and 4, informing policy-level improvements. Which leads me to the focus of the summary brief and the specific grant that we received support to provide technical assistance to Kaiser Permanente. Since 2010, OPIP has been working with primary care practices and health systems on how to better serve children overall, and specifically children with special healthcare needs. And what we have found here in Oregon that may be very similar to what you are finding in your own states is that while significant gains have been made in ensuring patient-centered medical homes for all children, and the development of coordinated care organizations has supported higher quality of care for publicly insured children, there is still a gap in specific supports focused on children with health complexity. And yet we know if we want to meaningfully impact children's future health and preventable chronic conditions, we need to address predictive social determinants of health and build resilience. In order to do this, we need a population and community-based approach that engages the multiple sectors required in addressing children with health complexity. One important piece of this approach is ensuring that there is a way to identify children with health complexity. As we all know, what is measured is what is focused on, and what can be identified can be resourced. Within Oregon and within Kaiser Permanente, previous to this project, there was not an existing standardized way that children with health complexity could be identified and quantified using factors related to medical and social complexity, so the construct of health complexity, combining the two. Furthermore, we have learned from our previous efforts that best matched care coordination and complex health management models designed for adults often don't work well for children. Secondly, the best matched care coordination depends. It depends on the level of health complexity and how much medical and social complexity exists for a child. Best match services for a child with high medical complexity and no social complexity are very different than what would be a best match service for a child with moderate medical complexity but very high social complexity. So this led us to the grant from the Lucile Packard Foundation for Children's Health to focus on how to address this gap in 1, data, and 2, best matched sets of services. The project supported us to work with Kaiser Permanente, which is what we're focusing on in today's webinar, and it also supported us to work with the Oregon Health Authority and their accountable care organizations, known as coordinated care organizations. We will be describing that work on April 2nd, which we will discuss at the end of this webinar. So now to get more in depth about our work with Kaiser. This and the past grant supported OPIP to provide consultation and support to Kaiser Permanente in their efforts to build, pilot, and evaluate a pediatric complex health management program. The assistance provided and described in the summary brief was supplying references, examples of models, bringing in experts, conceptualizing the health complexity methods to apply, and creating tools for Kaiser to consider. The underlying construct of the Kaiser Permanente Pediatric Care Together program is based on providing supplemental supports for a targeted population of children with health complexity that are often not provided by a conventional medical home team or by an exceptional needs care coordination team. In designing the program, the goal was to identify the right team to provide the right supports to children based on their medical and their social complexity. The summary is based on learnings gathered from the first pilot of the program in Mount Scott, whose team is on the webinar today, as well as learnings KP has gathered as they've spread the PCT model to another site. Hopefully you all have read the summary, as we will not be going through the content in details today. It's important to note that this is a snapshot of where the program is now as of March 2019. Given it is an evolving program that continues to learn and improve every single day, it is likely that Kaiser will improve on these tools over time and that there will be updates over time. Okay, so the summary that you hopefully all read beforehand is anchored to the one-page overview visual provided in Figure 1 and shown here. Within this figure in the document, there are hyperlinks to the specific components of the PCT model. Within each section, we provided you with specific examples of the tools, methods, and frameworks developed. As you can see, we outlined 6 main components of the PCT program that were conceptualized, developed, and piloted by KP Northwest. Section A in the upper left-hand corner describes the system-level data used to develop a standardized way to quantify and identify children with health complexity. This population-level data was critical in quantifying the need for a PCT program and the investment of resources requested, to develop a shared understanding about the level of pediatric health complexity that existed within a Kaiser Permanente population, to identify potential pilot sites for the program, to identify children who may benefit from further assessments, and to develop a population-based approach that you could then use to evaluate the impact of the PCT program relative to other populations in Kaiser. Section B then describes how the system-level data was shared with the primary care team and critical factors that need to be considered in sharing this data about child and family-level indicators. Section C outlines the primary care-based methods for identifying children with health complexity that could potentially benefit from further assessments by the PCT. This includes provider gestalt for children identified on the system-level data, so from A, as well as provider self-identification based on their knowledge of the child and using a health complexity construct. Lastly, this section describes a set of items that were added to surveys given out at well child visits. When we were identifying social factors in the system level data, so that's section A, we identified gaps in the information available. To address these gaps, 7 new questions were identified that could collect trackable data that then fed into the system level data to improve the accuracy and identification of social complexity indicators. Section D is where we're going to spend most of the question and answer period today because it focuses on this incredible PCT team that I have around me and focuses on the kind of tools that they use to provide best match services to children. So part 1D helps describe kind of factors that they consider in conducting assessments of children and who gets moved on to receive PCT services. And then within the rest of the sections, we provide information about the kinds of supports that the team provides, how they stratify the population they are serving, how they manage and document their care in EPIC, and how they thoughtfully transition a child from PCT services. Section E then provides an overview of children identified for PCT assessment that are not enrolled in the PCT program, or children that are transitioned from the PCT. And then lastly, Section F provides an evaluation framework and proposed evaluation metrics developed to assess the impact of the PCT program. All right. Enough talking about the concepts and design parameters. Let's now hear from the frontline people within Kaiser Permanente that developed this concept and, more importantly, put it into action. All right, so let's start first with the conceptual. Dr. Liu, the need for and the idea of the PCT program was your brainchild. You have managed to obtain philosophical support within your organization as well as financial investments in the PCT program. What were your keys to achieving this? What advice do you have for others listening on that are trying to obtain the political and financial support needed to create programs focused on children with health complexity?
Thanks. So one of the first things I realized as I was starting to come up with this program and looking for money to fund it was that there was a general belief from our senior leaders that kids are pretty healthy and awfully resilient and not very high cost. And as such, it explained why we hadn't funded a complex care program in pediatrics prior to this. But one of the things that I knew as a pediatrician is that if we didn't tackle some of these issues and build coping resiliency and social support for these kids early on, they then became very high-cost members afterwards for us. And we are very fortunate in the Northwest to have a very high retention rate. And so in educating our senior leaders on the impact of ACEs, making the argument that if we spend money up front, we should be able to save money down the road, we were able to get their buy-in and to say that they would fund the pilot program, and now we're looking to spread the program throughout the region here. And to quote a much wiser person than I, it's easier to raise a healthier child from the get-go by providing support and resources early than it is to fix a broken man later on. And that's something that we've been talking about here. By collecting the data on both medical complexity and showing that almost a quarter of our members have a chronic disease that most will bring into adulthood, in addition, looking at the social risk factors of our children, our population here in the Northwest, we realized 2/3 of them have at least one social risk factor, and the social risk factors we're tracking are actually mostly ACEs, not all of them, but mostly ACEs. And when our senior leaders saw the data and knew the impact of ACEs, they were willing to go ahead and give us some funding for this program. And before we go on, I just wanted to give a huge thanks to several people. You're going to hear a lot of work that we've done, and we're very proud of the work that we've done, but we know that we are not even close to being at a final stage. There's a lot of modifications still to be had, but we couldn't have gotten to where we are today without the grants that we've had, including one we're very grateful from Lucile Packard. And we've been able to get a lot of help from other experts in our country who are so wise and so gracious with their time. Dr. Rita Mangione-Smith, we've used much of the data that she has published. Dr. Rich Antonelli, Dr. Bergman were very kind to come to Portland to share their ideas with us and help us build the process. And of course, OPIP has been invaluable in the support, their leadership, and all of the resources they brought to the table. We look forward to hearing about your thoughts and feedback and any questions that you might have, because we would love to make our program even stronger. So thanks for listening in.
Thanks, Joyce. All right, let's get to some of the questions that we commonly get to. Can you go to the next slide and hit the arrow? Thank you. So one of the areas I wanted to focus on in terms of the questions for the team was on engagement of and assessments of children and families to the PCT program. This is an area that I feel like we get the most questions asked about, is like, how do you assess who should be in your program? And then how do you get families, particularly families with high social complexity, engaged in this type of program? So Kenan, why don't I start with you? What have been some of your keys to success in engaging children and families in the program and in your assessment?
So what we found from the beginning was that our program needed to be different, and there is a lot of fear of the system, and that it can't just be the child, but it needs to be the family. So a part of that was trying to meet in person, so that way they see the social work and services and resources that we're trying to help, and we're not trying to tear apart families. So having 5 minutes to really engage families and build that trust and rapport, and letting them tell their stories and letting them know that we know that they are the experts, and being able to meet them where they're at. So if they're not able to meet with us in clinic, because a lot of the times poverty is a barrier, and being able to transport over to where we are at is impossible for a lot of these families. So we want to make sure to meet them in the schools, in the communities, wherever it is that's close for them to either walk or to be. So being able to do that, being able to meet them where they're at, being able to work with them on their goals and saying, hey, we're just here to help and support you with that, has been instrumental in helping us to engage.
Stephanie, I'm curious, in your role in kind of helping families to kind of navigate the different systems and the needs that they have, what have been some of the biggest barriers that you encountered, and how did you address them?
So with resources, there's not really many barriers with talking with the families, because they usually will have in mind what they need. The barriers become when they're resistant, when they're not ready for the help. And so one of the things we have learned is to make sure to just, like Kenan has said, make presence, speak with the families in person, and make sure that we are available. So we make sure to speak with them and offer the support. We oftentimes will provide our contact information. We'll give them a list of ideas of different resources that we can support with. And at the end of the conversation, we remind them that when they're ready, they can give us a call, they can contact us, and we will be there to support them. And so a lot of the times, the main barriers is the resistance at the beginning. But once they are reminded that they are the ones in control and that we will be there when they're ready, they open up. And sometimes that helps open up in the moment. Sometimes they go home, they think about it, and then they call us back. But that has been very helpful.
I'm going to take a question from the audience just because it fits this section. So in terms of kind of engaging families, Dr. Lutz, I feel like you have an interesting perspective because you are a primary care pediatrician who's referring into the PCT program, and then you provide support to the PCT program. So what are some of the kind of keys to your engagement when you're trying to engage a family to say, I really think this program is important for you? As a primary care provider who they trust, what are some of the things that you found are keys to success in that?
So I think there's 2 parts to the answer, and one is hopefully as a pediatrician, I have rapport with the family and I can leverage that trust to recommend the program, and that's huge. I find it sometimes more difficult to recommend the program when I'm doing cross cover and I don't have a relationship with the family. The second part is I've started to fine tune the language I use to recommend the program. In the beginning, I was using the words, we have this neat program that I think could be of use to you, and the word program often scared people away and was cumbersome for me to use. And so what I found was more helpful was to do a more individual introduction. So for example, for Stephanie, who's our navigator, I might say something like, if a family had marked on the form that they have trouble with food resources, many of our families have similar struggles with food resources, and I work with someone who's called a navigator. Her name is Stephanie, and she's right here in clinic. Would it be okay if I introduced you to her so that she could talk with you about your needs and your goals and give you some ideas or resources that are local that you might find useful? And so I usually do a personal recommendation. We have the benefit of having this team co-located in our clinic, which is huge, so I can walk down the hall and grab her and she can come meet the family in person. And that has been just probably the top reason I think our program is so successful is the engagement in person.
All right, I'm going to throw in another question, but this is something we've talked about ad nauseum, so I know you guys can handle this one. So Mort Wasserman asked a question about, the system level data is identifying some children who may have high health complexity who actually aren't coming in. And so you wouldn't have an opportunity to identify them because they were kids outside your scope. And I know this has been a really interesting thing that you guys have kind of addressed of like, how do we engage those families that they're not coming into the primary care? So Joyce, do you want to take the start and then identify the best match team?
Okay, probably have Cannon speak afterwards. So one of the things that we've done is there's a couple of things. If they have a chronic disease and we know that they're struggling, for instance, we know they're a diabetic and they've been to the ER 3 or 4 times, and we know that they need to come in, we actually will go ahead and ask Cannon to try to reach out and see if we can't match them up in the clinic themselves. And if not, we'll have Cannon explain some of the other tactics that she might try to use instead of that. Often we try having their pediatrician or their doc with their best knowledge, so that could be our diabetes specialist, calling them and really having her go to the clinic and meeting them at that particular appointment. And it may be in her home clinic, but it may also be at a different clinic. Some of our specialty clinics are actually located at other offices and seeing. So Cannon, do you want to talk about, for people who we can't even get into the office, what you might do?
Yeah, so we have why our program is unique, and I think why it's been able to be successful is the fact that we're able to use the community resources. So say this is a kid that goes to school, we might not have a release of information at the time, but we might work with the school in order to help and collaborate a time for the family to come in so we can get a release of information, so that way I might be able to meet with them and talk about goals. This might be a kid who's in the ED, so then we can work and partner with our system that lets us know what ED they're in, even if it's not ours, to be able to meet and build that relationship with that family and get a warm handoff from the hospital staff, even if it's not Kaiser's. And then if they're in a residential or behavioral program, that's another great way of getting our foot in the door and being able to say, hey, you're in crisis right now, and these are short-term services, but since you are with our program and since you are with our clinic, we can go ahead and follow you and continue to follow you. So that way we can give you that case management and coordination, so that way it doesn't fall off, and just knowing like we're here to support you and we really care about you. And that's been really successful for a lot of our families that do have no engagement or have a fear of the system or aren't aware of the fact that, wow, this exists.
Yeah, thank you. All right, let's go to the next section, the next slide. Sorry, I just got pushed out of my... All right, so one of the kind of keys about the PCT program that I hope people picked up on and that you're already hearing is that it's a multidisciplinary team. And the reason it's a multidisciplinary team is if you are trying to address children with health complexity that have medical needs, that there are certain best match parts to that, and have social complexity needs that are certain best match parts of that, that you need this kind of team with different skill sets and different abilities to kind of provide the best match service. So I wanted to ask a couple more questions about that. So Stephanie, I'm curious about, in terms of the program supports, what do you think are the key elements of your program, and what supports have you seen be most meaningful to families?
I would like to highlight communication, transparency with the families, advocacy, and continued follow-up, just because I think from the moment we step into the room and we do present ourselves to the families, we try to communicate with them as clear as possible. And Cannon has often, many times, expressed the importance of transparency, just letting the family know from the beginning who we are, what we are here for, and always being completely honest with them. The other thing is that advocacy has been really important from the beginning, and also in educating the providers that when they are presenting us to the families, they remind them that we are here to advocate for them, because sometimes their needs may be social, they may be, but they may also be needing other type of support out in the community. And so the advocacy piece always reminds them that they're not alone, we're here to support them, and they will have an advocate for them. And the one last thing is the continued follow-up, just because one of the main things we often hear from families, or at least I have many times, is I already have other people who are supporting me and they're not doing much. Or they called me a couple of weeks ago, but I haven't heard back, and they said they would call again. And so they start to lose the trust. And so making sure that we continue the follow-up has been really important, and working with them until we meet their goals.
So one of the other things I wanted to mention is that our Kaiser phone tree can be very cumbersome for some of our members, and people are laughing here in the room. And so one of the things that we've done actually is give our members who are on our program the actual phone number to call, the cell phone number for the main point of contact, and that has been very helpful.
Shannon, I'm curious, why do you think this team with various people with various skill sets is needed to serve children with health complexity?
I think that way people can focus on their scope, which is really important. The pediatricians know and have been able to identify, and the pediatricians I work with are amazing at being able to identify the kids that need more help and support, but they have these 20-minute or 40-minute slots. So being able to work with us on what those needs are, and for, in my position, to be able to meet and engage and build that trust and work on goals, and for Stephanie to be able to do some of the work of the critical work of making sure that families have insurance and making sure that families are supported and connected with different resources in the area. So we're all able to work at our best scope.
Tim and Charlene, do you guys want to add anything on to that?
So this is Charlene. The portion of the registered nurse that we unfortunately haven't been able to have a robust system with that yet, just due to other circumstances. But having that nurse that's part of a team, working at the top of their scope, doing nurse visits, complex advice, and nurse triage, working in collaboration with the whole team, the primary care doctor, the physician lead, social worker, and navigator. This registered nurse provides care resources and education for those high risk and high utilizers to really help them enable them to self-manage their health needs and be successful with treatments and really understanding their disease process. And by understanding and taking ownership of their disease process and really having a full understanding helps that patient to be able to really be in control of their own health. And by having that registered nurse that can be that portion also helps to take that off of the primary care physician's workload, because they're able to spend more time and educate the patients around what those needs are to be able to care for themselves.
Can I just bring up one learning? Is that we were using the nurse that was working in the module. This is a very big module with many doctors in there. And that nurse, because of some staffing issues, maternity leave to be frank, kept getting pulled back into doing the clinic work. And our learning is to get funding, which we're shoring up right now, to have somebody specific to the pediatric complex care work. And I think that that will be much better than the nurse that we've had who keeps getting pulled back to do other work and hasn't been.
And I think a piece to add to that too is there's a huge value for having somebody who has a drive to be part of that team, somebody who has a drive to really take care of these complex pediatric patients. It doesn't add value to the team or for the patient if you have somebody who is just a fill-in person or somebody who doesn't have really a passion around the care. And that's not just the nurse, it's the navigator, the social worker. It's hard to build a relationship with a patient and have them have buy-in and being in control of their care if the person doing the work is not bringing that to the table also.
And to add to that, building the trust, it's important to have the same person building the trust over time and not having different people filling in over the same year.
The other thing we think that nurse role could be very helpful in, and what our clinic nurses weren't able to do, was to go to the schools to help advocate for IEP 504's mental health program, to go ahead and make sure that the school services were meeting what the child's needs were as well too.
Shannon, I'm going to ask you a question that we had kind of primed up, but a couple of people have asked in the question panel too, which is kind of, their question was, are all these visit-based supports? And one of the key parts of this has been that there's things you're doing over text. That was a key part to get in place. And then you kind of reiterated over again that for some of these kids, you actually need to meet them outside the clinic in order to get their support. So could you talk a little bit about the PCT team's non-visit-based supports and kind of different methods that you guys use to do that? And then share a little bit why you've seen it as so important and why from a staffing job description point of view, it's been really important to make sure that you could leave the clinic in order to meet patients. Okay.
that was a big question, so I will try to answer all of those things. So non-visit-based supports first, of like what other interventions we use.
Yeah.
So when we're not able to meet with them in the clinic, or if we're not able to meet with them in the community for whatever reason, whether it's a release of information or they're not coming in, we definitely try over phone calls. And this is a process that I think instead of having that mandatory primary of you only have 3 calls and then you send a letter and we're done outreaching, I think it's really important for our families that we continue that and engage with them, because it takes multiple phone calls for families to build that trust, and it might be something big enough to happen for them to finally say, okay, I'm finally ready for your help. Wow, I remember you calling me, you know, a couple months ago, and right now we're facing this big catastrophe and we really need your help and support with this. Why it's so important, though, to have those community-based visits is, again, you know, there's certain things you can do in a clinic that is really helpful, but you have to remember that a pediatric clinic can be a very traumatizing space, not just for the child, but for the family. You have screaming children around, you have shots given, and all of these things are something that a lot of families fear. So if you have that space to go where they're at, where they're comfortable, where it's in their community, they're going to be more open. They're going to share more information, and they're going to be willing to talk to you about their goals. So I think that's what we found is the difference. I think some of the pediatricians have seen that too, where they see maybe my patient saying 5 words to me in the clinic, but then as soon as we leave the clinic and we go to the school, you know, they want to talk about everything. So it's been really critical.
Kim, do you want to add some other context there?
Yeah, I was just going to give an example from the pediatrician provider end of what it was like before we had this team with one particular patient, and then what it was like afterwards. That kind of speaks to the care coordination and the outreach that was done. I had a patient, I'll call her Clara, was a young lady with lupus, chronic pain, depression. She wasn't taking her medicines regularly. She wasn't making it to school regularly and was at risk of not graduating. She wanted to go to counseling. She wanted to take her medicines regularly. She wanted to finish school. And despite my best efforts and the family's best efforts, we weren't able to help her to remember to take the pills, to get to counseling. I remember I asked her mom if we could call the counselor together through Medicaid, and the mom put all her cards out on the table that she had in her purse to rifle through till we found the Medicaid card, and then we tried calling and we were on hold, and then my MA got on hold, and then we got a voicemail, and they left a message to call back, and we knew that would probably never happen. And probably, you know, and that took tons of time on our end, obviously. And so that was her medical complexity, but the reason there was all these issues with her being able to take care of herself was the social complexity. So there was a language barrier. Their phone usually didn't work because they often didn't have money to pay the bills. The parents were working full-time jobs, so even when their phone did work, they couldn't answer the phone. There was food resource insecurity, and there was a big mistrust in the system. They would make half my appointments, but not all of them, but they would never make the specialty appointments for rheumatology or anything like that. And so she would show up in my office in severe pain and abdominal pain, and her depression was worse, and there wasn't a lot I could do because I knew what she really needed was to be able to get her lupus treated. So right about that time, PCT started, and our navigator and our social worker were able to work with the family and to identify some of Clara's goals. And so they were able to secure ride to care, just really practical things to get her 2 appointments for specialty cares. We ended up getting her infusions for her lupus so that she didn't have to remember to take the pills every day. The navigator worked with her with goals, which was to get to college, and really got her buy-in because they helped with scholarships. And you know, it was amazing when I talked with Clara about a year later, when she was doing really well. She said, you know, it's amazing when you don't have chronic pain, how your depression gets better and how you can go to school, and she was about to attend college. So I think sometimes these things are just small things, but they can make a huge difference. And as a provider, we don't have time to find all the resources. We don't have time always to sift through all the social risk factors that are going on that are preventing care. And most of these kids and families want to get better.
I'm going to ask Cannon and Stephanie a question that I've seen a bunch of questions in the panel about, you're obviously trying to coordinate services that happen within Kaiser. But a lot of what you're trying to coordinate then is services that have with providers that are outside of Kaiser. And so could you share a little bit about your experience with that in terms of what you've learned about community-based services and community-based support?
Yes, it's been critical, and it's been so amazing to see how, when you're willing to outreach and engage, and how they're like, oh, we can support this family with a case management view and making sure that everyone's kind of on the same page. So being able to send those release of information out and figuring out who the family is working with and advocating for support or being able to consult, because a lot of the times there may be us that doesn't have the history or the community-based services. So being able to share that information so that way we're all on the same page and we're not in disagreement and we're not working on different goals that kind of combat each other. So being able to have that partnership in the community has been critical, and that way we're not repeating services and we're able to enhance those services for the family. And that way the family knows that if something drops out of the way, we can help and advocate for those services to continue or figure out a new venue for them to get similar services or something else.
And with community resources or more material resources, some of the things that we often help them with are, for example, furniture that is often in person. So meeting them, that often is a door that is open with the families, because it can often be one of the biggest stressors for them if they know that their children don't have a bed, if they know they don't have furniture or a desk or a table for them to do their homework. They do open up after we're able to connect them with those resources. The other things that often help a lot too are transportation. I think with care coordination, bringing them into the appointments, transportation is always really helpful. And that may not be meeting them out in the community, but that is helping them over the phone schedule the appointment, meeting them at the door sometimes, or help by walking them over to where they're going to wait for their transportation to pick them up after the appointments. The reason that's often helpful is because of language as well, because we don't always help families who speak only English. There are many languages, and so just being able to walk them over has been also really helpful. And then for other utility assistance programs, we may not meet with them in person, or even while they're in the clinic if they don't have all the information they need, but they do go home, they give us a call when they're ready, and we will call the provider, the service provider, and help with guiding the conversation with them. Sometimes it's being able to request a payment plan. Sometimes it's being able to request actual assistance. And when they know that we're there to lead that conversation, they do feel very supported, and they do call us back after that for different types of supports, including care coordination.
Great, thank you. I'm going to have us go to the next slide because we have, again, an open section for questions. One of the common questions that people ask about is, how do you document the kinds of care that you're providing, and how do you leverage the kinds of different supports that you have within an electronic health record? And I know there's a lot of, one of the things we struggled with as a team is the really amazing model of the shared plan of care, but how difficult that is to actually operationalize a shared plan of care in an electronic health record environment in which that's what you're beholden to kind of document your information. And so I'm curious, Vicki, if you could share a little bit about how you guys built off the long-term plan of care template that's in EPIC, but kind of modified and enhanced it for this PCT team, and how they kind of structured it.
Sure. So the longitudinal plan of care is based on engaging with the patient and documenting their goals and really connecting and coordinating the care. So I just wanted to briefly cover what the elements of what we call the LPOC is. So once Cannon or Stephanie or anybody on the team has established rapport and is developing that relationship with the patient and family, the team, along with the patient and family, ideally collaborate to create that person-centered care plan, or what we call LPOC, which is documented in the chart, and it can be seen actually at a glance throughout the entire healthcare system. What's unique about it is that it's a living plan, so it really requires regular updating as, you know, as we have all seen members and families' systems and needs and goals do change. So what we include in the LPOC is the patient story, which includes a question of what's important to know about me, which in our setting really needed to include not only the patient or the child, but the other children as well as the parents and the family system that's caring for them. The other really critical elements of the LPOC is that the patient and family identify their own personal goals, and that is operationalized with the language, I want to, ... goal, and I will do the next action. So that's like small measurable steps to work towards that goal. The third element of the LPOC is that everyone on the team is assigned a main point of contact. And that main point of contact stays in close contact with the patient and the family and guides that patient's care through regular follow-up. And in addition to the, what we call the main point of contact, the other healthcare team members are added. And what we found with this particular program is that we needed to add also the community-based professionals that were helping with this child's care, as well as the school. Anybody that may engage with the healthcare system, we needed to include them and ways to contact them.
Great, thank you so much. That was so helpful. I know the LPOC or EHRs are kind of the big hard barrier. So let's go to the next slide. We have a lot of questions, and so what I'm going to try to do is kind of look at themes and then go from there. So one of the questions that is a super data dorky question, so of course, Joyce, you're going to know I love the data dorky question, is on that section A around system level data, there was a question about the pediatric medical complexity algorithm, which is an algorithm that looks at diagnosis, utilization, and number of body systems impacted. And the kind of standardized tool that we were able to build off that, again, came from Seattle Children's, uses ICD-9, ICD-10 codes. But within the Kaiser Permanente system, we kind of had to then think about that translation work of kind of how do you use EHR-based information and flags that correlate with those kinds of histories and diagnoses that are in the PMCA. So could you share a little bit about how within the integrated system like Kaiser, you guys kind of leveraged and used that PMCA model, knowing that the claims data is a little bit different here?
Yeah, so luckily, the PMCA model has SAS coding based on ICD-10 codes. So they changed from ICD-9 about 18 months ago to ICD-10, and there was a conversion for us. It was pretty easy for us because while we don't do billing necessarily for most of our members, if they're on the true HMO model, we still do chart and put the ICD-10 diagnosis codes and the CPT codes in there. And so we went ahead and used that in the most limited data set. So if you look at Rita's work, Mangione Smith's work, they actually will tell you that there's 3 different levels you could apply, and we did it to the most restrictive because our data actually is quite complete. And that is where we came up with our proportions of kids with chronic diseases, either complex chronic, the most chronic disease, or those that are chronic and non-complex chronic. And just to make sure you guys know, in the complex chronic are mostly diseases that will pretty much shorten the child's life. So they are really pretty severe. Some of the most aggressive cancers are in there. There's other things like muscular dystrophy and some pretty bad genetic syndromes in there where we would expect a child to have a fairly shortened lifespan. But in the non-complex chronic, I think pediatricians would be pretty surprised to know that pediatric diabetes is in there, asthma is in there, and there's other diseases like anxiety and depression are in there as well too, that can be debilitating for many of our families and actually tend to be very high cost because of the volume of kids that are there. Or for diabetes, if it's not being managed, it could be a very high cost member to us. But the thought of putting them in the non-complex chronic group is that those kids, if they're managed well and they buy into the treatment and they're adherent to everything we do, most of the time should live a pretty healthy life into adulthood and be maybe of somewhat higher cost, but not extremely high cost. So if you take a look at all our kids with chronic diseases, about a quarter of our population meets the criterion for non-complex chronic or complex chronic disease.
And one of the things we're going to be talking about is the April webinar, and we can share how we used the state data to run the PMCA. OPIP is based at OHSU, and OHSU has taken from the problem list in the EHR and created a version of the PMCA that's based on kind of EHR data alone, knowing that then it's limited to the services that they know about and the services that happen within their region. And so on April 2nd, we'll talk about kind of why there's value in having potential partners that can look across systems and across providers in order to get the most accurate PMCA classifications. Another question that we got was, have you guys ever supported teens who, as part of your PCT care and part of your PCT transition, are actually then transitioning to adult care? Has that been something that's come up yet in terms of your piloting work, or something that you're thinking about kind of moving forward?
Yes, that happens quite a bit. We reach teens maybe right when they're 17, or maybe we worked with them for a couple years and then they switch over to adult care. So at that point, we can do a couple of things. We can talk to the pediatrician and keep them on a little bit longer, because we know that we can provide them with intensive services that might not be available when they are an adult. Or what we can do is we can really work with the team if they do meet the level of need for the complex care team for adults, in order to make sure that that is a warm handoff. So that way they know that their trusted pediatric team supports this team as well, and that way they get to know them with us.
So I'll just add one more piece to that is our eventual goal with the kids who are on the PCT team is that hopefully we give their parents or them as young adults the tools to be able to navigate the community systems and us on their own and achieve independence. So some of the teens, as they graduate from our PCT, no longer need our level of service anymore and can enter that adult world without another team following them.
And I think that that's an important part, and that is some of the verbiage we tell our families pretty close to the beginning, to make sure they understand that we're not going to be doing the work for them, but we're going to teach them how to be able to navigate the system themselves. We don't word it in that way, perhaps, but that is our goal.
One of the things we have a couple of questions about is, part of the concept of the shared plan of care is that the plan of care is shared with the family, and that the family has that as a document. And so can you share a little bit about, within the LPOC, kind of what could the family take home? How would the family have access to that? And then I'd be really curious, I think one of the things that's been really interesting and hard to kind of navigate is how you do that in a way, particularly if you're serving a teen, and kind of who has access to what parts of the LPOC. So which one of you guys want to start first? Okay.
So I think that a lot of the times we do try to keep sensitive information off of there. We might go ahead and review the goals, especially verbally, I think has been the best way, especially when you have maybe a teen and a parent who don't see things the same way. For example, we have a lot of teens who are transgender or non-binary, and their parents may not agree with whatever their goals are, whether it be hormone treatment or the fact that they just want to use this identity and they want for their gender and their preferred name to be used in a school setting and other places. So we really want to make sure to be careful, especially when it comes to safety for our teens, especially if it's not known, especially if it's a matter of outing them. So making sure that we're keeping that information private and confidential. So a lot of the times we really want to make sure that, if there is this LPOC, which can be printed off with the after visit summary, that those things aren't included. However, if it is a family goal of, we want to make sure that we get the A1C level down, to an 8 versus an 11, then we want to make sure to maybe review that in the paperwork and go over it.
Because of the sensitive nature of some of our teen stories, there was discussion about printing the LPOC on the after visit summary, at least parts of it, but we have elected to suppress it in pediatrics for fear of some of the concerns that were brought up to us, and just wanting to make sure that we kept the trust of the kids at first and foremost.
Okay, another question we had was to kind of talk about that, like, when is your stop point of when you want to transition kids from your PCT care? Because obviously you're living in an environment in which you need to be really thoughtful about resources. And so one of the questions is, like, for how long are kids with complex medical conditions staying in PCT? Like, how do you kind of determine when they should stay, and do you have any goals about, like, our goal is to get them out of PCT by a certain time period?
I think this depends on where the family is at and how many needs they have and how complex they are. But no matter what, our goal is to make sure that their time is well spent with teaching them how do they advocate in the system, how do we get them the supports they need, how do we make sure that their natural community supports can be there, because we know that we are a time-limited program. So it's either a matter of it's a good outcome, and that's why they're graduated, because they know the system, they have the supports that they needed, and they are coming to their regular scheduled primary care visits, or it's the opposite, which is they're not engaging with us anymore and they're not ready for those services. So at that point, we might take them off, but letting the pediatrician know, hey, they're not ready right now, but let us know, and then we could try to onboard them again at a later time, or we'll try to outreach to them, but right now they're not ready for Pediatric Care Together, and we're going to move on.
Right, and I think that something to add to that is that we do have some patients who have a high medical complexity, but they have a very good support system. So they're not appropriate patients for PCT because they don't have a need for those resources for whatever reason. And so we're trying to get patients to a level similar to that even though they might have some higher medical and social complexity scores, that we're giving them those resources and tools so they aren't necessarily needing the services.
I think one of the other adds is that we're working on the intensity scale, and that sort of defines like how complex a patient might be and what are their needs. And so we fall on a range of interventions to patients that are really complex and socially have a lot of needs. So Cannon or Stephanie may be reaching out weekly, and then we have kids that we're following that we're reaching out monthly or quarterly, depending on the need.
So again, we have some questions that kind of go around non-visit based models and telehealth. And I wonder if you guys could share, I know at the beginning you were trying to run the program without texting ability, and then you got the ability for texting. And so I'm curious, that's an example of something that isn't visit based that has seemed to be critical, particularly for some of the socially complex kiddos. Could you share a little bit more about that?
Yes, I feel that since we've gotten texting in place, it's made a significant difference, just because a lot of families now either don't have the minutes and they have the ability to text, or they might be busy, they might be working, so the ability to pick up the phone and talk to a social worker or talk to the navigator just might not be there, but being able to meet them where they're at and being able to text them, which is most families' preferred method of communication, or able to meet them and they're able to express what they need. Even if it's, hey, do you have a minute, or finding out when you're available to talk more about this in detail, has been really critical, or being able to send a resource because, you know, they might be able to get it through the website and then they can click on the phone number, which has a hyperlink to be able to get to those services, or being able to put an application on there, or even using Google Translate because, you know, we don't speak, you know, all of the different languages, so being able to use those services to be able to meet them where they're at.
We have a number of questions. You guys mentioned the importance of engaging with schools. And so there were a lot of different questions that related to what degree are you working with school nurses, and to what degree have you kind of, what were keys to your success in terms of opening lines of communication with school, given a number of people had noted some barriers with that?
Yeah, so a lot of the work can range. So it's anything from working with school nurses to working with the IEP plans, or advocating for an IEP or a 504 plan. A lot of the times resources are very limited, especially in Portland around this. So families might not know their rights around if they qualify for an IEP or a 504 plan. So being able to go to the meetings has been critical in order to get families' needs met. When it comes to nurse support, whether it comes to to type 1 diabetes or something else, being able to, they might not know the school nurse might not be involved. So being able, again, to kind of do that warm handoff and being able to say, let's meet the nurse together. Let's see what can be done. Oh, look, you can have a private space to kind of check your meter in order to give yourself insulin. So there's a lot that can be done in being able to kind of build that relationship and being able to hand it off to the school and for them to be able to reach us through a direct line. So that way all needs can be met.
And I think to add to that, the medical portion that schools are, at least in Portland, are lacking school nurses at all sites. And so there's been a lot more kind of openness and willing to communicate and partner because we're actually helping to educate the schools on how to help some of these patients with some of these medical complexities like diabetes, seizures, and things like that.
And I know from the provider end, pretty much everyone in our office knows to always get release information for everything. So whenever we hear, for example, like I had a mom recently whose kid had autism and they downgraded the amount of support they thought he might need, and he was running from the school daily, and she had to leave work every day to go get him. So there's a big safety issue, and she's having trouble getting a meeting with the school to relook at his IEP. And so, you know, we have releases of information all over the clinic, and my medical assistant knew right away to get that release of information for the school, and then Ken was able to get involved. So that allows her to communicate with the school.
Yeah, if that can be part of the practice, I think that's really great. If you know that there's going to be school problems, to go ahead and get a release of information signed right away, so that way we can communicate with the school, and it's one less step, especially if they're in the clinic.
And we have HIPAA and FERPA forms actually available to us, and that would be really a good idea for those in other places to have that too.
I think the only thing I would add is just that for some schools, it was a real culture shift for them to have active involvement from a medical system. And so the benefit of having, I think, can be persistent and open and receptive, like how do we collaborate together, and like really repeating that message over and over again, I think really helped a great deal. Because sometimes it was just a, no, we're not interested, right? We're doing our own thing.
All right, we only have 3 minutes, so I'm going to pick a easier, quick question in the sense that, Joyce, some of the questions have been about scope within Kaiser Permanente, given this is being currently piloted in one site and then has spread to another site. How many PCPs right now, in terms of that section about PCP availability to refer into the PCT program, how many PCPs right now are referring into the PCT program because it exists within their sites?
So I'm going to look to Kim. I think that there are 14 pediatric providers at Mount Scott, and additionally between 25 and 30 family medicine providers as well that will refer into the program there. At Mount Scott, it is about half of that. So I think they have 7 providers in pediatrics.
Rockwood?
Rockwood, I'm so sorry about that. Yeah, thank you. And about 20 family medicine doctors there.
Right. Okay. All right. Well, I think that we only have 1 minute, so I think what we'll do is we as a team will review the rest of the questions, and if it's easy for us to get back to you over email or we'll post the questions online, we'd be happy to do it. And thanks for some of the people who posted questions that have links to resources specifically focused, for example, on adolescent transition. We really appreciate as Joyce mentioned, this is an ongoing learning. Unfortunately, we kind of started with we started with an adult model that didn't work, and so we started with a blank page. And so I think as much as we all can share with each other, that's how we're going to progress the field forward. And those of us doing this work on children with health complexity, we need to learn from each other because it's going to be something that we're going to encounter barriers and bumps along the way. All right, so you can go to the next slide. All right, so as I mentioned, the grant that we received from Lucile Packard also supported us to work with the Oregon Health Authority. So before we conclude this webinar, we just wanted to make sure that you knew that on April 2nd, you should register for the webinar that we're going to be doing that will be spotlighting our work with the Oregon Health Authority and how the state is maximizing system level data they have access to across a number of state level systems in order to address health and social complexity in children. Thanks everyone for joining today. We really appreciated all the great questions and look forward to continuing the conversation.